Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and today I want to tackle pneumothorax decompression, a core skill in emergency medicine, but I think there's some real room to improve over the classic teaching. Most of what we're going to talk about applies to situations where immediate decompression is needed. Typically, this is with a tension pneumothorax. The classic teaching is that patients with a tension pneumo are going to have absent breath sounds on the affected side, tracheal deviation, and hemodynamic instability. But classic doesn't always reflect reality. Absent breath sounds can be a challenge because of ambient noise as well as transmitted sounds from the unaffected side. Tracheal deviation typically occurs late, if at all, and hemodynamic instability is obviously an important finding, but it can be due to numerous pathologies. The key is recognizing when to suspect that tension pneumo, rapidly identifying and then rapidly relieving the issue. We should suspect this in any patient with hemodynamic instability after chest trauma. That's kind of an easy one though. Another common place to consider this is in the mechanically ventilated COPD or asthma patient. Always consider pneumothorax if the mechanically ventilated patient decompensates. The other place where I occasionally see this missed is after a central line is placed, particularly in intubated patients where there's positive pressure, and that positive pressure can worsen a small pneumothorax very rapidly. It's important to remember that pneumo can occur after both subclavians and IJs, even if you're using an ultrasound. The fastest and most accurate way to confirm the diagnosis when you have a suspicion is with POCUS. Drop that probe on the chest and look for the absence of lung sliding or the lung point sign to confirm your diagnosis. A standard teaching for immediate treatment is to do needle decompression followed by a chest tube, but I have a lot of issues here. Number one is that we're taught to do needle decompression in the second intercostal space in the midclavicular line. The problem with that location is that there's a lot of critical structures in that area. The aortic arch, great vessels, the left atrium if you're on the left side. Additionally, there's data showing that we often misidentify that second intercostal space in the midclavicular line, and we tend to go lower than indicated, and that increases the chance that you hit a critical structure. The second big issue with needle decompression is chest wall thickness. In many adults, the chest wall is too thick to penetrate even with a long angiocath in that location. This is a real concern because even if you identify the right space, you might put the needle in and not rectify the situation, and you might not even know that you didn't get your needle into that pleural cavity. If you're going to decompress the chest with a needle, the better approach is to place that needle in the fourth or fifth intercostal space in the anterior axillary line, basically the same place where you would do a chest tube. The data shows that the chest wall isn't as thick in that part of the chest, making it more likely we reach the pleural cavity. But this still runs into two issues. If you're on the left side, there is the danger of plunging that needle into the left ventricle, although it is relatively low. Number two is that even though the chest wall is thinner here, there's still no guarantee you're going to get in with the needle. The better approach is to skip the needle completely and go right to a finger thoracostomy. This is basically making an incision with a scalpel in the chest at the fourth or fifth intercostal space, anterior axillary line, just like you would for a chest tube, penetrating the muscles in the pleural with a hemostat or even just with your scalpel, and then placing your index finger into the incision through the intercostal space and into the pleural cavity. The advantages here are that you absolutely 100% know that you are in the chest cavity, you're less likely to puncture any critical structures, and you've done the most important steps in chest tube placement, which at some point you're going to have to do anyway. Over the last 5 to 10 years, I have moved completely away from needle decompression. If I need to decompress a chest, it's going to be a finger thoracostomy every time. Now, before we wrap up, let's hit a couple of take-home points. Number one, suspect a tension pneumo, not just in trauma, but also in mechanically ventilated patients who become unstable after a central line is placed, or just in mechanically ventilated patients who become unstable. Number two, if you suspect a pneumo, confirm with POCUS if time allows. And finally, number three, needle decompression is a suboptimal approach for decompression of the chest. Finger thoracostomy is much more likely to be successful. That's all for the Rebel Core Content Podcast this week. We'll be back in a couple of weeks for another cast, and until then, don't forget to pop on over to the site, check out all of the fantastic posts from our faculty, and until next time, stay safe.